All right. Greetings, everyone. This is Eric Glazer, your host and moderator. And this is the Population Health Executive Roundtable. Right. Greetings, everyone. This is Eric Glazer, your host and moderator. Hang on for a second, everyone. I just have to, I've got a bunch of buttons. I'm trying to do too many things at once. All right, we're going to stream this live on YouTube, see if that works. Greg, you can hear me okay?
I can hear you perfectly.
All right, here we go. All right, so welcome back, everyone. I know we typically produce one live event per month. These are not typical times. So this month, we are actually planning on 4 events. This is our second one. And unlike our typical roundtables, today I'm interviewing one-on-one Dr. Gregory Katz. So here's how our special live conversation with Greg is going to be organized. We're going to cover some questions around ethical dilemmas that physicians are facing during the COVID crisis. And then we're going to switch over and talk a little bit about innovation, what the hospital, the medical center where Greg's at, what are some of the things that they are doing on the fly around innovation, and some of the ideas that Greg has for opportunities to innovate moving into the future that maybe someone in the audience at your organization, maybe you could capitalize on, I don't know. So our hope is you'll get a lot of information. We have sprinkled in your questions that you submitted upon registration to be included throughout the flow of today's conversation. A lot of your questions are included in today's plan of action. But if you have a new question or did not submit a question upon registration, if you scroll over your Zoom interface, you should see at the bottom of your screen a Q&A module. My lead producer, Sherry Keels, and I will be monitoring that, and we'll try to bring in questions from all of you into the conversation as appropriate. So we'll try to get through all of your questions. And if we can't, and we'll be talking more about this in a moment, or later on in the show, I should say, if we can't, on Tuesday at 4 p.m., you can mark your calendar right now, Tuesday at 4 p.m., Dr. Katz will be back with us for a live fireside chat where you could actually have a two-way conversation with him. But I'll get into more details about that later on. All right. So we should have you all covered for today through your questions. Also, if you have not already, please subscribe to our podcast. It's called Bright Spots in Healthcare. It's often I speak one-on-one with leaders in healthcare around the industry, and we dive deep into topics that that we cover often, whether it be physician engagement, social determinants of health, behavioral health, etc. Our podcast interview, our interview with Dr. Harry Sag, who we featured about a week and a half ago that many of you attended, that's on the podcast feed now. The conversation we're about to have with Dr. Katz will be part of the podcast feed. And we're also going to take some of our roundtables that we've hosted recently and actually convert those into podcasts as well. So Bright Spots in Healthcare, it's on Apple Podcasts, it's on Spotify, it's on Google Play, it's on all your favorite podcast apps. Take a look at it, subscribe, it's free, and give it a listen. Thanks so much in advance. All right, let's get down to it. Greg is in Poughkeepsie, technically, Poughkeepsie, right?
Technically correct.
Yeah. All right. So Dr. Gregory Katz is a cardiologist. He's part of Hudson Valley Heart Center and Vastra Brothers Medical Center, which is about a 450-bed tertiary hospital out in Poughkeepsie. It is a Nuvance Health affiliate. Greg specializes in preventive cardiology, coronary artery disease, disorders of cholesterol and metabolic syndrome, a group of conditions such as elevated blood pressure and sugar that occur together and increase your risk of heart disease, stroke, and type 2 diabetes. He is presently working in the ICU at Vastra Brothers Medical Center, treating COVID-19 patients. Dr. Katz earned his medical degree from NYU School of Medicine. He completed his fellowship in cardiovascular disease at NYU's Langone Medical Center and was awarded the Fellow of the Year not once, not twice, but 3 consecutive years during his fellowship. He completed his internal medicine residency also at Langone and was selected to serve as senior chief resident, a educational leadership role within the training program, and has been published in more than 15 scholarly publications, including book chapters, and peer-reviewed articles. He also publishes an email newsletter featuring his thoughts on health, medicine, and COVID-19. We'll tell you how to subscribe to that for free at the end of this show. All right. Well, welcome, Greg. I appreciate you taking the time. Why don't you set the stage for us and tell us a little bit more about your current role at Vastra Brothers Medical Center?
Yeah, so thanks so much for having me, Eric. It's a great opportunity to sort of share what I'm going through and what my hospital is going through, dealing with these complicated patients. So I was hired to work as a cardiologist and see cardiac patients. And then COVID comes along and all of a sudden our cardiology volume drops and our COVID patients sort of overwhelm everything. And so our demand for cardiologists in the office has basically evaporated. And we've had this great need because our ICUs have become overwhelmed with intubated coronavirus patients. And so I've actually been working about 3 or 4 shifts a week in the ICU, taking care of both COVID and non-COVID intensively ill patients. And so I'm doing some additional cardiology consultative work as well, but the majority of what I've been doing for the past, I guess, month, maybe even a little bit more, has been COVID. Honestly, the time kind of blends together in this weird era that we're in.
So besides the obvious lack of supplies, PPE, and obviously the high patient volume and the personal risk that you're putting yourself in the way of, and you just had a newborn child, right? So congratulations.
5-month-old, thanks.
And besides all of those challenges, what are some of the biggest challenges that you're facing as a physician as we sort of close out April and enter into May, outside of, well, you're really right there in one of the hottest areas in the country as far as this crisis goes?
Yeah, so I would say there's the personal challenges that I'm facing with regards to, I'm a fish out of water in the intensive care unit. And, I've done a lot of ICU training in residency and in fellowship, but being the ICU physician of record is a brand new experience for me. And all of the kind of issues that you might think would go along with that, the pressure, the lack of facility with some of the procedures that I haven't done in years, going back and doing those again is really difficult. But then there's the sort of societal challenge of treating these patients, which is that they're really, really sick and nobody really knows what works and what doesn't in them. And we're doing the best that we can to treat them according to the standards that we have for the sort of other parts of the COVID infection that we know how to treat. Like, we know how to treat ARDS. We treat that with, which is, ARDS is the medical term for the fluid filling of the lungs that you get with a severe coronavirus infection. That's often what leads to your intubation. We know how to treat that. We know how to treat a viral pneumonia, which is part of what this virus is. If you get a blood clot, we know how to treat that. But there are so many aspects of this disease and how it affects all of our organ systems that we're flying blind, and different people have different ideas about what medications might work, what medications do work. And as you see with sort of like the way that the media represents a lot of the potential treatments, we're in an era where nobody knows what the right thing is. And so the medical profession in many ways is flying blind and trying to research the right treatments as quickly as we possibly can. Eric, I'm having some difficulty hearing you actually right now.
Because he's myself off mute, but all right. So I was saying, I'm going to take a question from the audience right now. At this person's hospital, they've started screening all admissions for COVID, not just suspects. Are other hospitals, to your knowledge, doing this? Or are you guys doing that at Vassar?
Everyone's doing this. I think that the fact that the nasal swab now has a rapid turnaround in most places with regards to, I guess taking a step back, there are a lot of different ways that that people diagnose different infections. And for a coronavirus infection, what we're doing is something called a nasopharyngeal swab, which is an incredibly stiff Q-tip that you basically jam into somebody's nose as far in as you can go, and then you wiggle it around and you're trying to collect the virus's genetic material. And so you send it to a lab and it tests for the virus genetics. That test is about 80% sensitive, meaning that 4 out of 5 patients who have a COVID infection will test positive using that test. It's a crappy test, but 80% sensitivity in screening all comers gets a large proportion of the people who are coming in with this infection. And so everyone that comes into the emergency room gets a nasal swab done and tested for a COVID infection before they're able to come off of any kind of isolation.
So when we talked in preparation for this, I thought it was interesting to hear some of the different dilemmas you've been put in that are unique to the time period that we're in. So we're all we can't escape, like unless we turn off the television and the news and don't use our computer, everything that's in front of us is COVID, COVID, COVID. And so we're hearing different reports about different diagnostics, different therapeutics. What are some of the dilemmas that you're facing day to day because of all that information and the fact that the hospital's close to family members of your patients?
So we are seeing patients who get sick and do poorly despite every standard of care that you could use for a critically ill viral pneumonia patient. And we're seeing blood clots happening in weird places. We're seeing people who are developing kidney failure and then having blood clots form in their dialysis catheters. We are seeing people who have these insane oxygen requirements that are kind of like beyond what you would expect based on what a typical viral pneumonia does. We're seeing people who have multi-systems of their body where all of the organs are failing. And we're seeing incredibly, like astoundingly high levels of inflammation. We're seeing sepsis like you don't see in typical either bacterial or viral infections. And so you have this constellation of patients who are having strange manifestations and really serious manifestations of disease. And we have all of these reports out of China from several months ago, out of Italy, and now starting to come out of American hospitals that are giving us a lot of information about the characteristics of this patient population. And what we're seeing is that they have all kinds of weird manifestations of disease. And one of the things that's getting the sort of two things that seem to me like they're getting the most media play are the quote unquote cytokine storm that patients are having, which is this huge systemic inflammatory response in their body where it's hypothesized that the virus isn't what's doing the damage to the people who get really sick. It's that their immune system is responding in a almost out of proportion manner to what's going on. The other weird thing that we're seeing are that these patients are developing blood clots in a way that critically ill patients don't normally develop blood clots. And, you know, if you look at autopsy reports of these patients, what you see are not only do they have big blood clots sometimes, like a blood clot in their lungs or a pulmonary embolism or a heart attack, like things that are big blood clots. They also have microscopic blood clots in lots of different organ systems in their lungs and their kidneys. And so we don't know the extent to which abnormal blood clotting that's probably driven by the inflammation associated with treating this disease or with your body responding to this disease is causing blood clots. We also don't know which patients we should be preventively treating, if any patients. And so the challenges of dealing with those sort of two unexpected manifestations of disease, the blood clotting and the cytokine storm or the systemic, almost an autoimmune-like response, those are real challenges. And when you're dealing in an area where there's kind of like a data-free zone, it gives everybody, one, a huge amount of anxiety regarding, am I doing the right thing for my patient? And then there's the idea of, well, if I'm seeing all of these things and these patients are doing poorly despite all of the quote unquote standard of care treatments, should I be thinking about what makes intuitive biologic sense to me? And should I be trying out those treatments on my patients who seem to be going south despite my best efforts?
Are there specific specific treatment dilemmas and conundrums that you've faced? Maybe if we could go back in time, let's say 3 to 4 weeks ago, leading into today, as far as different things where it's hit the press that this could be a treatment, you get a phone call pushing you to go in that direction, and whether you did or not, you could let us know, and sort of what were the results, and maybe kind of get us up to speed to today, where some of the current news, the fake news, the real news, and how you're kind of absorbing all that.
Fake news.
Yeah.
So kind of like going back 4 or 5 weeks ago, we were talking about hydroxychloroquine, which is the generic name of the lupus drug Plaquenil, in combination with an antibiotic, azithromycin, as potentially a way of tamping down the immune response to this virus. And these medications in vitro, meaning in a test tube, seem to have activity that block the effects of the virus on our system. And so this was being given not just as a treatment to all critically ill patients with COVID, but there were a lot of providers who were taking this prophylactically, as we think that this might have effect. It has a long track record of being well tolerated. And so what's the harm? Well, one, the harm is that there's a risk of cardiac arrhythmias, meaning abnormal heartbeats that can be life-threatening as a consequence of either one of those medicines alone, but the combination of them in particular seems to be particularly dangerous. And then there's the idea that as we've studied it, the trials don't look like patients are really doing that much better. And that fits with the clinical experience of everyone who was taking care of these patients. Because if hydroxychloroquine was a miracle drug that fixed COVID, we would know, because we'd be giving it to patients, and we were giving it to patients, and we were seeing that they all did poorly. And we're seeing in my hospital about 75 or 80% of the patients who need a ventilator are ending up dying. And that is similar to some of the data that was just published out of the Northwell Health System in the New York, Westchester, Long Island region, which are also, I think that they had an over 80% death rate in patients who were sick enough to be on a ventilator. And so if hydroxychloroquine and azithromycin was a miracle cure for COVID, it would be obvious, because all of those patients wouldn't be dying. The next thing that kind of got a lot of press was an antiviral medication that's manufactured by Gilead called remdesivir. Remdesivir inhibits viral replication. It was initially an Ebola drug, and it has activity in a test tube against SARS, against MERS, and now against the SARS-CoV-2 virus that causes the COVID-19 infection. And we were treated to news reports out of Chicago and out of a handful of other places that were saying that patients getting remdesivir were having a remarkable turnaround in their symptoms. And so Gilead was planning a clinical trial that right after their stock kind of went up through the roof, there's their clinical trial to test remdesivir compared to a placebo in critically ill COVID patients. They made 2 major changes to that trial. One was they increased the sample size of the trial from several hundred to several thousand patients. And then they changed what their outcome was, where their initial outcome was death or days free of a ventilator. They changed it to a 7-point scale connoting the severity of disease. What those 2 changes say to me when they're done in the middle of a trial is that the data Gilead is getting back from this medication shows that it is not a miracle drug, because if it was, they wouldn't need to expand the trial to show a benefit, and they wouldn't need to change their endpoint from something very clear like death to a 7-point scale connoting severity of disease. And so, and remdesivir was initially only available under compassionate use, which basically means the company needs to approve whether or not a patient gets this drug. And then they published results in the New England Journal of Medicine that looked really, really promising. But that wasn't compared to a placebo. And when a drug is not compared to a placebo, we don't know if people get better because of that drug or if people get better in spite of that drug. And so seeing that patients are getting better who are given remdesivir doesn't really tell me all that much about what impact remdesivir is having apart from placebo and all of our other treatments on the natural history of this disease.
Now I'm hearing within the next week or two, we should have some new results from double-blinded studies here in the US, right?
I don't know about the timeline. I'm not privy to those meetings. What I was hearing from some of the whispers in the hospital is that it was probably more middle to end of May, but I think within several weeks, we're going to have something published.
Sure. Let me, there's a bunch of questions coming in through the queue. I want to clear up some of the queue right now as we move on to sort of innovation. So this attendee has asked, I've recently heard of skin presentations of COVID. In your practice, have you had any patients with this?
I have only been taking care of COVID patients when they're sick enough to be in the intensive care unit. A lot of people who are critically ill and who have sepsis-like syndrome will have different types of rashes. I personally haven't seen it, but if you look at all of the different ways that this disease is manifesting, even something like the loss of sense of smell says to me that the virus is probably infiltrating the nerves. And I think there was a report that I had read about a meningitis picture from this virus. We know that the original SARS virus can invade the neurologic system. And so I wouldn't be surprised if this virus was able to enter almost any type of cell in the body. And a skin reaction can be a direct result of a toxin or of an infection, but the skin can also be sort of like a secondary marker, meaning it's the body's response or the body's immune response to an invading pathogen that's leading to a skin manifestation.
Have you had to do any CPR on patients, and what's the success rate? So
patients who are admitted to the hospital who have a cardiac arrest that's not due to a heart attack have an abysmal success rate of CPR, even when we're not in the age of COVID. And the way I usually frame this thinking to a patient is that there are two different types of cardiac arrests. There are cardiac arrests that are due to a problem with the heart, which is usually a heart attack, and that's usually something that's treatable. And that's the sort of thing where people are more likely to survive CPR than in the other scenario, which is that the heart stops because the rest of the body is failing. And when the heart is stopping in response to the rest of the body failing, the success rate of any kind of resuscitation is really low because that's only treating a symptom of what's going on. It's not treating the underlying process. And so we're seeing awful, awful numbers from our COVID patients who have cardiac arrests. And that's from talking with my colleagues at other institutions and from reading the literature. That seems to be kind of a universal experience, which is completely consistent with what we would expect based on our prior understanding of cardiac arrest in the setting of a real severe systemic illness.
Okay, a couple more questions and then we'll move on. And keep them coming, keep Q&A module at the bottom of the screen if you've joined us late. Keep those questions coming in. All right, is there any concern that patients who are speaking English as a second language, so they're limited in speaking the language, are being treated fairly?
I have no concern that those patients are treated unfairly. Hospitals have pretty robust interpreter services. And hospitals that take care of large numbers of these patients will have interpreter phones in every room. Patients that don't take care of large numbers of non-English speaking patients have phone interpreters that are available 24 hours a day. There are cultural barriers to some of the discussions about end of life goals and the sort of manifestations of how we would want to treat somebody and instructions about coming back to the hospital. But in terms of do those patients get the same quality of care as patients who speak English? I think there's no question that the answer is their care is similar.
All right, I'm smiling because this is like total current event, right? So a recent press release mentioned disinfectant, what type of chemicals are safe for humans to digest in the body?
Food and FDA approved medications. I wouldn't even put nutritional supplements in that realm. Without being sort of like too critical of the idea of disinfectants, I don't think that you are going to find credentialed medical professionals who think that there's any merit to that idea.
Got it. Let's move on. Here's a more clinically oriented question. Have you started to use the filters on dialysis that remove the cytokines like Cytosorb? When in the disease process have you implemented it, and has it been effective?
So I think the premise of this question is that the body's immune response running rampant is what's leading to a lot of the deterioration in really severe COVID infections. And there are a lot of different ways of treating an immune response that's gone out of control. The sort of like oldest way to do this was to use steroid therapy, like high doses of prednisone, basically, to tamp down the body's immune response. That's a crude drug. That's a sledgehammer. The newer wave of things that we've been doing are more targeted, what we call biologic therapies. Things like medications like tocilizumab, which is an interleukin-6 inhibitor. It's thought that interleukin-6 is one of the hormones or one of the chemicals in the body that's most responsible for this out of control immune response. And so there's a medication called tocilizumab. The trade name is Actemra, which blocks the action of interleukin-6. That's something that we're using for some really critically ill patients. The mechanism of treatment that was proposed in the question was using a dialysis membrane to remove the circulating chemicals that we think are driving the immune response. That's not something that I've done. And two, I'm skeptical that it works because of how crude it is as a treatment, and it's not targeted at any one specific thing. And I sort of get the sense that this is going to be we're going to need to treat the immune response with a scalpel and not a sledgehammer. And we're going to need to figure out specifically which chemicals in the body or which processes in the body are driving the out of control immune response, which may be different for different people. And then we're going to need to target those specific factors. I could be wrong. It could be that using a membrane to filter out something during dialysis or a plasmapheresis like procedure is something that's going to be really effective, but I'm not optimistic about it.
Okay, I want to transition. Keep the questions coming. I see a few of them in the queue right now that I think I'm going to integrate into our innovation portion of the discussion, which is about to start. Just some announcements as we're reaching the halfway mark. In about 20 minutes, you're all going to receive your feedback, a link to a feedback form. It's a Survey Monkey. Those regulars, I send this to you, and I'm going to hound you about it. It's really important. We know that an hour of your time, especially in the middle of the work week, is incredibly valuable. And it's a privilege to have you guys trust us in taking time to join us whenever we put on these events. And we use the survey to gauge what content is most valuable to all of you and what we could do better to serve you more effectively in the healthcare industry. So we're really pains in the neck as it relates to filling out the feedback form. So in about 20 minutes before you even get off this call, you'll receive an email from me. And we ask you the favor of it just takes 2 to 3 minutes, mostly multiple choice, to provide us with some feedback. To that end, and I mentioned this at the beginning, we're going to host a special fireside chat with Dr. Katz and our shared friend, Dr. Harry Sag, who you might have all seen on our show about a week and a half ago. And they will just have a two-way discussion with all of you regarding your additional questions, and you get to meet the other attendees. So it'll be limited to about 15 or 20 folks. So it's first come, first serve, and you could request to register for that through that feedback form that I just alluded to that will be coming on in just a few minutes. Also, just a quick little commercial for all of you who are working in healthcare and are looking to reach payers and providers. I want you to consider using events, certainly virtual events now, in your marketing and lead generation strategy. And if you do that, whether you're doing that on your own or not, I would like you to consider working with us, Shared Purpose Connect, to accomplish this. We produce these virtual events from soup to nuts, and we work with your team to incorporate you as a thought leader. Those of you who are regulars know that we typically do more panel, 3 to 4, 5-person roundtables during our events, although we are excited to do these one-on-one live interviews, which is part of our Bright Spots in Healthcare podcast. So we would integrate your thought leadership either into the roundtables or the podcasts or both. We also work with you to produce different marketing content derived from the event. And finally, we assist you in your lead generation, your networking. So we become an important extension to your marketing team, and we have been able to move the needle with big companies like Vituity, a Commonwealth Care Alliance, Lumeris, and smaller organizations like Revel Health and Roster Health. They're all partners to the Population Health Executive Roundtable. So if you're curious about what that would look like, I ask you the favor of emailing me directly at eglazer@sharedpurposeconnect.com. And we could set up a no pressure brainstorming meeting and see if it makes sense to work together moving into the future. All right. Back to the show. So, Greg, I want to get into the opportunity for innovation. So tell me, from where you sit, where are there needs for innovation? We were talking, Harry had mentioned when we were on stage together, Harry had mentioned that the need for sort of remote infrared control over the oxygen titration within the hospital room. Where are there other areas where you think digital healthcare providers, innovators, technology companies that may actually be in the audience right now could work on producing something that can make life a lot easier for you as a clinician and your colleagues today, and also maybe in the future post-COVID crisis?
Yeah, so when I think about what the COVID crisis has illuminated as a real challenge of taking care of patients during a pandemic, the first thing that comes to mind is the frequent trips into a patient's room when you need to don in a 10-step process and then doff in a 10-step process, and the PPE that you're using, the time that you're spending getting ready to go in. And so when I think about innovation, the first place that my mind goes is, how can we minimize unnecessary trips into a patient's room? And one of the strange things that we're seeing with this disease is that there's a lot of worsening of people's diabetes, and and even people who don't have diabetes will have uncontrolled sugars during their time in the hospital. And in the current state of affairs, what we do is we do a finger prick where we check someone's sugar manually, and then we adjust insulin dosing with an injection. And there's a device, or there are multiple devices that are called continuous glucose monitors, which are things that you stick onto your skin and you wear for either weeks or even longer at a time to continuously monitor what your blood sugar is like. And there's a company called Dexcom that does this almost exclusively. There's another one that's made by Abbott, and I'm sure there are other players in that market. But we don't use that for inpatient medicine. We only use that for outpatient medicine. And adapting some sort of continuous glucose monitor for critically ill patients would save a lot of stress. It would lead to fewer finger sticks, and I think both patients and clinicians would like it as well. And similarly,
before you leave that, what if I showed up with 500 of those at your hospital tomorrow? Are you able to use them?
We would need to go through the various compliance procedures. It's not something that exists. So one, it doesn't exist in our current inpatient order set. Nurses are not trained in how to interpret it or put it on. And so there would be an educational process to that, because anytime you have a new device, you need to demonstrate that it's safe and effective, which we have data on that, but you also need to make sure that staff is facile with it and is able to to integrate it into their workflow. And so all of these innovations, any innovation or any change to the way care is done will certainly have an activation energy that needs to overcome before you can have it fully sort of like seamlessly integrated.
You were okay, and you were going to mention another one when I.
Yeah. So the other thing that I think hospitals almost everywhere are doing are using IV extension tubing to get the IV box and medication dosing from next to a patient to out of a patient's room. And by having it out of the patient's room, you really limit the number of times you need to go in to adjust the rate of IV fluids or something along those lines. The other aspect that—
Well, you're doing that right now, right?
We're doing that right now in most hospitals, I think, and we're definitely doing it at Vastra. When you're adjusting a ventilator on somebody, so a ventilator in most cases is going to be an electronic piece of equipment that you need to adjust using an analog control. And so I know that there would be hurdles in terms of like sort of integrating a wireless mechanism of control or a Bluetooth mechanism of control into the way that we're treating these patients. But to make a ventilator adjustment, I would need to go into the room, or a respiratory therapist needs to go into the room in order just to twist a dial on a machine. It doesn't involve touching the patient. It doesn't involve anything. And so I know that there are hurdles in terms of the IT security and making sure that there's no ability to have sort of outside actors manipulate ventilator settings without being the care provider. But it's certainly an area of innovation that would save PPE and would speed up the way that we're taking care of these patients.
Let me ask you sort of a follow-up from the audience. There's a question around oxygen treatment, so I figure this is a good time. You had mentioned earlier in our conversation the incredibly sad mortality rates of a patient once they get put on a ventilator. Is there evidence to support that supplemental high-flow oxygen treatments is proving more effective than ventilators? And if you can, before even answering that, just for the group, distinguish between the two who may not be just savvy with the jargon.
Yeah, so a ventilator is a breathing tube that goes into your mouth, through the throat, and into the lungs. And it provides either a targeted volume of air or a targeted sort of pressure sensing of how much air it's going to give you. And in order to be on a ventilator, you need to have a tube inserted into your throat. It's invasive. You also get put on a whole bunch of different medications to sedate you. And the reason that you need to be sedated is that if you are not synchronous with the ventilator, and when we're treating these COVID patients who have the real diffuse kind of fluid buildup in their lungs, we need to do something called low tidal volume ventilation. When you do low tidal volume ventilation, it's almost, the way I sort of liken it, it's like if you're gasping for air after running up a flight of stairs, and I tell you you're only allowed to take half the size of the breath that you really want to take. And so we are manipulating the amount of air people are getting, and it can make people really sort of go nuts. And what I mean by going nuts is that they're dysynchronous with the ventilator, they're moving around, they're bucking the equipment, they're biting the tube. And so we end up using these very high doses of sedatives, and sometimes multiple different classes of sedatives, in order to adequately sedate a patient so that we can treat their lungs. Every time you give somebody a new medication or you perform a procedure on someone, you expose them to the unique risks of whatever that intervention is. And so when you're putting patients on multiple types of sedatives, or you're paralyzing a patient with a medication that doesn't let them move any of their muscles, there are risks with every single one of those interventions. High flow nasal cannula is a special type of supplemental oxygen that has two sort of prongs of tubing that go into your nose. They don't go deep in, they're just in. It's the sort of nasal cannula treatment that you see everyone who's admitted to a hospital on any TV show has, the little thing in their nose. But a high flow nasal cannula is actually providing a much more aggressive degree of supplementation. And it's also pushing in with a little bit of pressure to keep the airways open. The idea of giving a high flow nasal cannula is that if you're able to avoid intubation, which is the term for what you need to do to put someone on a ventilator, you avoid all of the potential complications and downstream effects of having someone ventilated. That said, there are going to be people for whom high flow nasal cannula will let them avoid being intubated. And that's fantastic. But then there's a group of people for whom high flow nasal cannula will be ineffective. For that group of patients, then I don't really see a way that you get away from putting a breathing tube in. But the sort of premise of the question of, are we intubating too many people? Are we intubating too quickly? Do we not give people enough of an opportunity to either fail non-invasive ventilation or to prone themselves, meaning lie on their stomach, which opens up the lungs a little bit better? Are we not doing that as much as we should? Maybe. I do think that what COVID has taught us is that anything that we can do to push off the need to put a breathing tube in is probably a good thing. And so if high flow nasal cannula lets 5% of patients who would otherwise be intubated avoid that mechanical ventilation, that would be fantastic. We're still waiting on data. And I don't know if the patients who get better with just high flow nasal cannula alone would have had a complication of having a ventilator, or if they would have done just fine with the ventilator, and being able to stay on the high flow nasal cannula is just a proxy for less severe disease.
Right, there's a lot. Keep the questions coming. I'll try to get follow-up questions many of you may have around that topic of oxygen if you want me to throw them in the last 20 minutes here. I want to take a step back. We were talking about the extended tubing for the IV bag. There's a question, looks like from a hospitalist, whether it be a nurse or physician, I'm not sure. How do you scan the patient to administer meds via IV when the pump is outside the room? This has been our hurdle.
The nurses are so it's not to start a medication, it's to adjust an existing medication. And so, when people are on the ventilator, they're on all of these sedating medicines. They're also very frequently requiring medicines that keep their blood pressure from dropping too low and raise it up. Those medications, the sedation and the medications that adjust the blood pressure, are not medicines that we're turning on and turning off or starting new ones all the time. We're using that extension IV tubing for adjusting the doses of those medicines, not for starting a new one. And so that two-step check-in process is something that has not been an issue for us. But to start a new medicine, to confirm that it's the right patient, yes, of course, you need to go in the room and do that kind of two-factor identification.
Okay, I'm going to go back to ventilators. So 2 questions, one from an audience member, one from me. So at what point, how many days after someone is intubated, do they need to be converted to have a trach? And then follow up is, what are you guys doing at Vastra that's maybe considered unique or innovative as it relates to intubation in general, and how you guys are handling that process?
So, we're trying to delay trach on these patients for as long as we can. Normally, we would start thinking about a trach after a week or so on a ventilator, but COVID patients are on the vent for 2 weeks or more. And so we're not doing any trachs on people until after day 14. And from talking with colleagues and in other locations, it's definitely something that seems to be the trend. And part of the idea is that if you are traching somebody prematurely, you're going to expose the staff who are performing that procedure to a fairly high risk situation. And as far as, I think the second part of your question was, what are we doing at Vastra that's unique or innovative? We're doing a lot of proning patients. And proning is when you have a patient lie on their stomach, as opposed to lying on their back, which is a term, the medical term is supine for that. And so when you prone people, as I had sort of mentioned earlier, you provide a lot more lung area that can be available for ventilation. And we're doing that for, traditionally, that is only done in severe ARDS, severe lung disease, in patients who are on a ventilator on 100% inspired oxygen with sort of all of the ventilator parameters turned up. And what we're doing is we're using it ahead of time before patients need the ventilator, with the idea of staving off the need for intubation. And so it's been, honestly, I think that we've been surprised with the experience that we've had of patients that we thought were going to need to be intubated who haven't needed to be. I don't know if it's that they would have done okay with the standard treatments, or whether we're actually making a real difference in what their trajectory would be. But we're seeing really, at least anecdotally, encouraging outcomes from that.
Okay, that's great. And actually, that's not where I thought you were going. So that was bonus, but I'm gonna push you where I wanted you to go too. So regarding intubation,
Yeah.
that's a risky procedure for the providers, right? It's probably one of the, correct me if I'm wrong, the most highest risk procedure as it relates to this virus for the providers. How are you guys at Vastra handling that to reduce the risk?
We've kind of innovated in the idea that we're having different teams of physicians perform almost assembly line-like tasks. And so we have a group of physicians that are doing our intubations. We have a group of physicians that are placing the central lines, which are special types of IV that need to be put in under ultrasound guidance so that you can give people medicines that raise your blood pressure. And we're also having specific teams that are communicating with family members of these patients if the doctor is unable to. And so what we're trying to do is streamline the care plan so that everyone knows what their role is, and that the doctor who needs to be following up the labs and the chest x-ray and the vent and making all of the medication changes for a patient doesn't also need to do the time-consuming tasks of putting the line in, which is something that you don't need to know anything about the patient to do that effectively. And so innovating in the idea of different teams doing different tasks is something that has streamlined our process a bit.
Okay. So Greg, next week, and I haven't made this announcement yet, but it ties into a question. Next week on Thursday, so 2 days after your fireside chat, I'm going to be hosting a roundtable where we're going to bring in a panel of experts to talk about communicating with payers and providers during this crisis. You know, organizations that sell in innovative ideas, technologies, vendors, lack of a better way of saying that, that sell into your market, whether you put on your, practice, your cardiology practice hat or not. What are some potential tips, communication tips, that you could provide all of them on driving innovation in a time of crisis when you're all looking for things like this, but you're really very busy? So, people knocking on your door, selling things may not be something you have time for right now, but at the same time, you're dealing with the tyranny of the urgent and there could be a solution in play. What would be some advice to everyone in the audience who may be in that role on what they could do? And that could be a good way of setting the stage for next week.
The easier it is to integrate a solution into our existing processes, the more likely we are to integrate that. The less training that's required to get staff up to speed, the more likely we are to integrate that. And I would really just say, like, the usual friction of any type of adoption of either new technology or new processes, the more minimal that can be, the greater the likelihood that you're not going to lose somebody who's potentially a decision maker with regards to purchasing.
Great. All right, we still have about 10 minutes for questions, folks. Here's one. How much preparation did you have, I think Vastra have, for scarcity decisions related to ventilators and other life-sustaining equipment?
So we were preparing for this from January when the cases started sort of cropping up in China. And I think our hospital was already buying additional PPE at that time. But we started having conversations about how to allocate scarce resources and how we could have as many ventilators as possible very early on. That said, nothing can prepare you if the onslaught is more than the upper limit of what your expectations were. And so we've been lucky in that we haven't had to split ventilators, which it's a whole host of complicating factors and difficulties and risks for the patients. But we had, we knew about this for several months. And I think that most people who were in risk management for hospitals had some sense by February that something was going on and that this might come to us. But nobody had any idea that this is what it was actually going to be, or that we were really going to be facing. And so we were better prepared than maybe somebody who wasn't paying attention to this, but nobody was prepared.
Two looking back questions. And looking back, what best prepared you to face the challenges of treating COVID patients, especially someone that typically isn't in the ID world, right?
So I think the fact that nobody knew what this disease was, and nobody still really knows what this disease was, means that no one had decades of experience in how to treat COVID-19. And what that meant is that there's been a really rapid dissemination of knowledge. And from my personal perspective, what I can say is that Twitter has been really instrumental in me having a chance to see different perspectives and to read a whole lot about what's published on this disease. And so I think that the way that physicians and other healthcare providers have banded together to sort of share the knowledge and to share our experience, and the rapidity of which data has been published has been really encouraging and has led us to at least have some sort of shared knowledge base, even if the right methods of treatments are still a little bit elusive.
Great. Looking back question. What could you, your colleagues, your hospital have done better? You saw it coming in February. Here we are now, probably, I don't know how to put a timestamp on where we are relative to this journey, but
Right.
We're in the middle of it. What could you, if you could go back in time, what would you do differently?
So the two major areas that I think would be what I would recommend to other hospital systems who maybe haven't been as inundated thus far as some of us in New York have been, is number one, have a staffing plan so that you can upstaff and have different tiers of upstaffing that would be triggered at certain patient volumes. And expectations of which doctors are going to be removed from their usual duty and put on COVID duty, which nurses, which clerical staff, which is sort of like every tier of the healthcare treatment team, who's going to be removed and then at what thresholds they're going to be switched, and making it very, very clear to those staff members what the expectation of their service is going to be. The second thing is that I think healthcare systems do a really good job of communicating via email to staff about what's going on. And so I can tell you, I get 4 or 5 emails a day from leadership of my organization about what they're doing, what our numbers are like, what changes to policies are being made, what is not being done as well. And what I think that I wish we had done from the beginning is have very clear graphical representations of things that we're using all the time. So for example, the nasal swab, as we had talked about earlier, to test for COVID stinks, misses a lot of cases. And we don't know when we're allowed to retest. Can I retest the same patient 5 times? I've had tests sent back and saying that maybe I shouldn't be ordering this test. And so I think having very clear graphical representation of these are the things that should trigger a second test would be really helpful. The other thing would be very clear graphical representation that's sort of put up all over the hospital of this unit is going to be a COVID unit once we get to this threshold of patients. And so people get inundated with email. And I know that I have trouble keeping up with all of the email I get. I imagine many listeners are very similar. And when we're wearing all of this personal protective equipment, checking your phone to make sure that you're looking at your email and seeing the latest policy change is not something that's as easy to do as we might like. And so having very clear, printed out, repetitive graphical representation of this is our testing algorithm, this is our isolation protocol, this is what our upstaffing needs are going to be. That would be really helpful. And I wish that we had done that a little bit better.
Right. All right. We have 5 minutes left. I know there's a bunch of questions. I'm not going to get to everyone. Again, Tuesday, 4 o'clock, live fireside with Greg and Dr. Harry Sag. You could ask your questions. We have 2 questions I want to get to. One is an ethical one, one's an innovation one. I'll probably flip-flop them in the order I ask you in the last couple of minutes here, Greg. Just final reminder to folks, Tuesday, 4 o'clock, fireside. Thursday, 12 o'clock, we're going to be doing that communication marketing to payers and providers panel. Hope you could join us for those 2 events. Greg, how you mentioned you use Twitter a lot. How can people find you on Twitter?
Gregory Katz.
Gregory Katz on Twitter, and the newsletter where you're updating folks on COVID. How could people subscribe to that?
GregoryKatz.substack.com.
Say that slower. GregoryKatz.substack.
Substack.com.
Okay, great. And if you guys missed that, email me. I'll send it to you through email, and you could subscribe to Greg's newsletter and get a lot of his thoughts as this thing progresses for however long we're in it. All right, here we go. What is happening with innovation? Keep in mind, we only have about 3 minutes here. What is happening in innovation that you haven't seen before COVID-19, whether it be funding, resources, willingness to do something, to overcome a challenge, et cetera?
Everyone is focused on a single disease for the first time in probably since the bubonic plague. And, researchers who were looking at cardiovascular disease or cancer are being repurposed to look at COVID. And people who have these huge research portfolios are completely shifting their focus. And so I think that that's going to drive a lot of rapid innovation here.
Great. Okay, guys, by the way, Sherry was kind enough on the chat to put the link to Greg's newsletter right there. So you can copy paste it, put it into your browser right now and subscribe. So thanks, Sherry, for that. All right, probably the last question. This is a good one. Looking at my other screen here. All right, ethically, what is your concerns? How do you feel about the ethics of mandating a vaccine when it finally comes out?
I don't know the answer to that. That's a hard question. I think that it's probably the right thing to do, but I don't know where we're going to be in terms of herd immunity and treatments by the time that a vaccine is available. I tend to think that we should all get it, but I think that we should all get the flu shot, and lots of people tend to opt out of that. This is clearly a different animal that we're dealing with. I'm hesitant at any point to mandate something because I worry about if we're mandating this, who's the dictator about what gets mandated and what doesn't, but I tend to be in favor of mandating it.
What about when the lockdown's lifted about just getting tested before you're allowed to join the rest of the world?
The test stinks, and that not just the nasal swab, but the serology test to look.
And when you say it stinks, because it's the efficacy, the false positives, the false negatives.
Yeah, it's 20% false positives, 20% false negatives, and so
it's only 60% accurate.
I don't know that's exactly how the math works out, but it's not accurate enough that we can make any kind of decisions with precision. And so I hope the test gets better. I hope it gets more precise, but we're not at a point where I think that you can get sort of like a get out of jail free card. You've been infected with COVID, go about your life, no social distancing for you.
Gotcha. Greg, thanks so much. Reminder, everyone, if you want to hear more from Greg and actually get to meet him, put on your best shirt, comb your hair. You'll be on video with him 4 o'clock, along with Harry Sag, 4 o'clock on Tuesday. That's East Coast time. Thank you all for taking the time. Please take that survey. It's in your inbox right now. If it's not, check your spam. And hopefully we'll see you either at Tuesday at 4 and Thursday at 12 for our panel, or both. Huge props to you, Greg. I really appreciate it. I know how busy you are. This was really helpful and useful. Really appreciate it. This will mark the end of our call. Stay safe, everyone. See you next week.
Okay. Bye-bye. Thank you.
Thanks, Greg. Great job.
Were you happy with how that went?
Really was. We're still on, just